Welcome to the Research Works podcast. My name is Dr. Dana Poole and I get the privilege of bringing to you a very special series this week. I am here in Slovenia at the European Academy of Childhood Disability, interviewing the researchers and presenters about their work. This is very exciting and I can't wait for you to delve into this whole research conference series. We hope you enjoy the series. Welcome back to the Research Works podcast, our very special edition here at EACD Slovenia 2023. So I have another wonderful guest today to be able to talk about her poster. So welcome to the show, Rose Elekanachi from McGill University.
Thank you so much for having me. I'm excited to be here today.
Oh, I'm so glad we met yesterday. Yes. It was brilliant. And the minute you told me about your research, I was like, okay, we've got to make sure we bring you on here to talk to you about this. So the title of your poster is The Development and Validation of a Cost of Care Questionnaire for Children with Arthrogryposis, Multiplex Congenita, a Caregiver Perspective. So many gold words in there. So let's go back a little bit in terms of like why you decide to go into this area in the first place.
That's a very wonderful question. Thank you so much for having me on the podcast in the first place. First thing first, I'm Nigerian and a physical therapist by profession. And in Nigeria, during my practice as a physical therapist, I understood or came to understand that so many conditions in pediatrics kind of fell into this spot of they would come to the clinic for treatment and they would disappear for a while. They do that again and disappear for a while. And it made me ask the questions of what exactly is going on. Why is it that you come for treatment and you disappear? And parents then would say, oh, I did not have enough money to come for treatment, or I did not do this, do that. And begs my concern of it's important to try to figure out, caring in the first place is a lot of work.
Yeah.
And arthrogryposis on its own is a rare condition.
Yeah.
And so many conditions like cerebral palsy, Down syndrome, Duchenne's muscular dystrophy is one that they talk about a lot.
Yes.
And research has been done in this light over and over again. And for a condition like arthrogryposis, where it is 1 in 3,000 children who actually come down with this condition, very rare. And you can be in a small city and it's just only you and your child that has this condition.
Yeah.
And it's kind of hard to figure out, support systems, how to go about it.
Yeah.
So therefore, that's like my lab, Dr. Naomi Danan in Shriners Hospital, and I found out about her and I was like, you know what, I would like to do research on caregivers' perspective in the rare condition. And from there, I can translate that kind of study back home to Nigeria where
Amazing.
maybe it's, of course, in other conditions, but arthrogryposis is kind of important because of how rare, the rarity of it, and how it's important to go away from the very popular ones for a while and try to figure out how to support this, families who...
That's wonderful.
Yeah, the condition is
that's
not
really
very
wonderful.
often. Yes.
Well, for our listeners and for just a bit of a recap, because it is such a rare condition, give us a bit of a 30-second rundown, I suppose, on what the condition actually is. What are the main clinical features that we might see?
That's very interesting. And arthrogryposis, like I mentioned, 1 in 3,000 comes with a group of a whole condition in general.
Sure. Okay.
So the main thing is the musculoskeletal affectation, which is the muscles and the skeletal component of the body presenting. It's mostly joint contractures, muscle stiffness, weakness, muscle weakness in general, and then it kind of relates into stiffness as it progresses along the line. Okay. So in different children, it presents differently depending on the type.
Okay.
There are different types, and based on genetic formation and genetic composition, it kind of varies over time.
Okay.
So a child with arthrogryposis, some could present with just, upper limb affectation. And when I say upper limb, I mean like the upper limb, the hand. And sometimes it's just the lower limb. Sometimes it affects the spine. Sometimes it affects the face, speech and all that. And sometimes it also goes into the cardiorespiratory, depending on the type.
Right.
So it kind of varies.
Yeah.
Exactly.
And so would it be considered a progressive condition?
It's following... Because it's rare, research is still ongoing. Right now, people say it's non-progressive in the sense that whatever the child is presenting with after, like once the birth happens, is what they would have to take care of over time. So therefore, like to my complete knowledge, I might be wrong. What I know about arthrogryposis to date is that it's non-progressive. Whatever is presenting at birth is what the parents are going to have to deal with throughout the child's life.
And I guess it's the natural things that with growth, you might see it might appear like it's progressive because there's growth that's happening alongside it, right?
Exactly. That's what happens. And over time, then as the child begins to grow and go through developmental milestones, different things begin to show up and begin to come through, and then you begin to have to see a different healthcare professional to deal with the different presentations. Exactly.
Yeah, that's great. Okay, that's a great description. So now tell me a little bit about the caregiver perspective and why you wanted to go down that path, because obviously looking at cost of care is really important. So tell me how those things relate.
Very interesting. So, when in the adult world of healthcare profession, we've looked into, when you're caring, a person with a particular condition doesn't care for themselves most of the times, and they have someone who's there to give them all the support that they need to go through. Now, for a child who needs care, on a typical child will need care to get through from 0 to a particular age before they can care for themselves. Now, for a child who has a condition that comes out with contracture, comes down with a lot of muscle weaknesses, they need someone to support them.
Sure.
Now, when we're supporting the children through the medical line or through the healthcare line, there's someone who's also there that's caring for them. That so many things about their life is changing because of their child. And most times it's always ignored because they're like, oh, it's the parent, they're taking care of their child. But there's an extra work that comes into taking care of a child with some form of disability. So therefore, the reason why I wanted to go into caregiver's perspective is I wanted to hear from the person who is on a 24/7 basis with this child, understands everything, sometimes better than the child if care is not taken. So I wanted to understand from their perspective, how does this cost, and when we say cost of caring, us being here at the EACD today comes with a lot of costs, like flights, hotels, and all that. And that's just regular stuff. Imagine now a parent who has to do extra medical care, extra medical appointments, extra therapies, adaptations to chair, to wheelchair, to writing materials, to even schools. So all that adaptation costs a lot of money.
That's right.
And it's attributed to the caregiver, not the child, because the child is not working. And there's so many things that come with like the healthcare system in different countries that some things are covered, some things are not covered. Sometimes the child gets to 18 and the parents are stuck with, okay, what do I do now with this child? Like, how do I support the child going forward? I've done my bit and now they're seeing their colleagues, go to work or go to college. How do I support them through this aspect? And that also behoves on the caregiver as well, sometimes the parent. So I wanted to look out from there and see how can we now support this caregivers to make sure that whatever happens, because if anything happens to the caregiver, it affects the child sometimes negatively. So if the caregiver is completely okay, everything, they have all the support they need, the child also gets this support indirectly.
And I think that's something that we're increasingly recognizing more and more in research now, is that the child doesn't come in isolation. They're not the ones coming to us saying, I need you to fix this or help me with this. It's the parent that brings them along. So there is this, that parents love their children, caregivers love their children. They want to find ways to help their child. So they'll probably do more than they have resources for, and we need to understand what that looks like.
Exactly.
So I love how you described that. So now can we go into this cost of care questionnaire? Your poster was all about the development and validation of it, right?
Exactly.
So what did you find?
So what I found in general, as a PhD student, you go through the process of doing a comprehensive exam at McGill. And during my comprehensive exam, I tried to go out there and find out what exactly is available when it comes to a cost of care questionnaire. And I realized there are cost of care questionnaires, but some of them are specific to the adults in adult conditions, and some of them don't completely collect costs, and there are three different type of costs. Any economist out there might challenge me on this, but the ones that I know completely is the direct cost, indirect cost, and psychosocial cost.
Okay. And
these three costs: direct is the physical money, indirect is opportunity cost, and psychosocial is the social changes that happens with the condition. So these three, some of the questionnaires I found did not have all three costs. Some had two, some did not. Some had only the money ones. And I wanted a questionnaire that had all three. Okay. And I realized I didn't have any of that in childhood disability specifically. Right. So I decided to create one. Now, I didn't create one out of the blue. I looked at all these questionnaires, found out exactly what are the main components, how does it relate to what I want to do. And if you look at that poster properly, it has 5 challenges that I identified during my comprehensive that I tried to address for this particular questionnaire. So therefore, understood what content I wanted in the questionnaire, defined the different aspects I wanted to be in the questionnaire, then also involved I did the caregiver engagement.
Yes, good.
I involved parents, about 5 caregivers to help us in the pilot phase, to let us know what questions the questionnaire actually are good enough. How many are the questions cumbersome? Are the questions too direct? Because when we're talking about cost, it's very finance. It's kind of hard to talk about sometimes.
It really is, isn't it? This can be so much stigma associated with it too. When you start going down that level, it's always awkward. Don't ask people how much they earn.
Exactly. You don't want no parent wants to feel like they're being asked that is the child a burden to them financially.
That's right.
So we went through the pilot and the phase validity state of the questionnaire to make sure that the questions were okay enough and so great enough. The study has started. The questionnaire is now out on Qualtrics, and we've had good responses.
Okay.
So those are the processes went through the construct definition, went through developing the items, also doing the pilot phases we did with healthcare professionals, caregivers, and we also went through the phase validity stage with caregivers as well.
There's so much work involved in creating that, but you want to be able to assess the right things so you get the right outcome. So it's worth doing. So where is this current measure? What is it called?
It's a cost of care questionnaire.
Cost of care questionnaire.
Yes.
So can anyone access it at the moment, or is it just for the study?
So it's just right now. It's just for the study. We're hoping that when we finally, because we're currently in the field stage, field testing stage.
Okay.
When you're creating the measure, you do the pilot phase, phase validity. You then do a field testing. Then you finally say this questionnaire is all good. It can be translated and used in other conditions. But right now it's House on Qualtrics, translated to French and Spanish, also available in English. We're using it to collect data on the cost of care of caring for a child with AMC between the ages of 0 and 21.
Okay.
We have currently 68 participants who have filled out the questionnaire. We're hoping to get up to 300, but it depends.
Okay.
We could cap it at 100 or 150 depending.
Okay.
We're also doing interviews. And we're trying to also collect more details through interviews, open-ended 60-minute interviews, to figure out if there's any details I've forgotten, and also factors associated with this that we cannot really capture with our questionnaire. And it's a 35 to 40 minutes questionnaire.
Okay.
A lot of time.
Yeah. And I think it's hard to have them. I mean, we always want to find ones that are just like 10 minutes, but they don't cover it, right?
Exactly.
So it's really tricky. So it's that balance is really tricky.
Exactly.
Well, it sounds like you just got a little bit of work ahead of you.
Yes,
there.
I do.
Just a little bit. All right. So let's go to the part where we can talk to clinicians who are sort of out there working potentially with this population. What will be your number one tip from what you've done so far of what they can do?
Great question. Now, coming to this, I did an interview. Like I said, I'm doing an interview at this moment. I did one yesterday. I landed here yesterday, and I did an interview like 2 hours after.
Wow.
And there was one thing I took away from that interview. It was that healthcare professionals should be careful of things they say to patients and caregivers of patients.
Gold.
Now, why? Some people say, "Oh, do I need to play safe?" No, you don't have to play safe. There are things you're saying to a parent that to you as a healthcare professional, you're saying the right things. You're saying what you have to say. But how does it translate in the ears of the parent? Are you putting fear in their hearts by what you said?
Yeah.
Are you making them feel like all hopes are lost? So when you are sharing your concerns, also share them, but also share support system. Don't just say, well, this is bad, this is not going to work, but also say, if you decide to go this way, these are the supports and things that are available. And that's why we're healthcare professionals, is to provide all the available supports. What support do you think your patients need? Aside from saying everything is wrong, everything's going to go bad. Please let's try as much as possible to give whatever available resources we think are available in our different countries. Because it's one of the biggest things I've heard over and over again. I've done 5 interviews now, and everybody says everything that's going wrong. Nobody shows you what supports are available in the country that you're in. So parents now become like the best librarians. They look out for resources, become extra resourceful, and things you hear from you're like, wow,
learn so much.
I did not know that was available in this country, or this was available here. So we should go ahead and resource. We should be very open to looking out for resources that would help support our patients.
That's great.
Very important.
That's great. And I love how you said that too, because I think words have meaning.
Yes.
And you want to always be careful. You don't just say something just, off the cuff, because what can be just a moment on our lips
could define.
Can really, and you send someone down this whole path, right?
Yeah.
So I think that's really important. And when we come to the topic of the caregiver's perspective and the cost of care, and there's 3 elements that you were talking about when we're talking about cost, we can actually have a role to play in each of them. And hope is very, very important too, and providing the right support. So thank you so much. That was a great chat. It sounds like you've got so much work ahead of you, but that makes it a PhD, doesn't it? That's the great experience.
Thank you so much.
So lovely to meet you here in Slovenia.
It was nice to meet you as well. I appreciate the time.
Oh, wonderful, wonderful. Well, to all of our listeners, remember you can head to our website, researchworks.net, where you see some notes about our chat today. And do just stay tuned, because there's so much more to come. But for now, thank you.
Thank you.
And goodbye.
Bye.